Good evening to everyone, and welcome to this important webinar, Confronting Racial Health Disparities in Mental Health. I'm Cindy George, a veteran health journalist, Pulitzer finalist, and past NABJ parliamentarian, currently pursuing my master's degree in public health to learn more about
Good evening to everyone,
and
welcome to this important webinar,
tonight.
Confronting Racial Health Disparities in Mental Health. I'm Cindy George, a veteran health journalist, Pulitzer finalist, and past NABJ parliamentarian, currently pursuing my master's degree in public health to learn more about. Good evening to everyone.
Okay, is the feedback gone? Let's try that again. I am Cindy George, a veteran health journalist, Pulitzer finalist, and past NABJ parliamentarian, currently pursuing my master's degree in public health to learn more about these issues and to work on solutions like the ones we will discuss tonight. The racial inequities crisis in our country's healthcare is unconscionable and unacceptable. The United States is also one of the most dangerous places to birth a baby among developed nations, particularly for Black mothers. Pregnant women in the United States are more than twice as likely to die from complications related to pregnancy or childbirth than their counterparts in most of the world's highest income countries. The sad reality is that women of color in the US are disproportionately impacted. Urgent action is needed to address persistent health inequities and ensure all mothers receive the best possible care throughout their pregnancies. Tonight, we will address the current state of racial disparities in healthcare, along with strategies to change those inequities and solutions to improve the Black maternal health landscape. This discussion is powered by Blue Cross Blue Shield Association, whose 35 member companies provide health insurance for 1 in 3 Americans, and will feature a preview of the association's research, the Health of America Report, Racial Disparities in Maternal Health. We are delighted to spend this hour with esteemed health equity leaders. First, this year, Kim Keck became the president and CEO of Blue Cross Blue Shield Association. Previously, she was president and CEO of Blue Cross and Blue Shield of Rhode Island, where she drove initiatives across cost and value stewardship, convenience, and comprehensive health, and led policy efforts fortifying elements of the Affordable Care Act. Ms. Keck also combated social issues influencing health outcomes, including childhood obesity, housing insecurity, and racial inequities. Before that, Keck spent 28 years at Aetna, holding various leadership roles. She serves on the boards of directors of Oak Street Health and Evolent Health. Give the audience a wave, Ms. Keck. Thank you. Congresswoman Lauren Underwood serves Illinois' 14th Congressional District. She is also the youngest African-American woman to serve in the United States House of Representatives. Congresswoman Underwood co-founded and co-chairs the Black Maternal Health Caucus, which elevates the Black maternal health crisis within Congress and advances policy solutions that improve maternal health outcomes and end disparities. Prior to her election to Congress, she was educated as a nurse and public policy professional and distinguished herself as a career public servant at the U.S. Department of Health and Human Services, where she helped implement the Affordable Care Act, broadening access for those on Medicare, improving healthcare quality, and reforming private insurance. Give the audience a wave, Congresswoman. Thank you so much. And our final panelist is Dr. Rachel R Hardiman. She is a tenured associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She is the Blue Cross Endowed Professor in Health and Racial Equity and the founding director of the Center for Anti-Racism Research for Health Equity. A reproductive health equity researcher, she applies the tools of population health science and health services research to elucidate a critical and complex determinant of health inequity: racism. Her work aims to link structural racism to health, identify opportunities for intervention, and dismantle the systems that allow inequities. Please say hello to the audience. I'd like to extend a warm welcome to all of our panelists And now we will hear from Blue Cross Blue Shield Association President and CEO, Kim Keck.
Excellent. Thank you, Cindy. It's great to be with you. And what an honor to join this esteemed panel, both Representative Lauren Underwood and Dr. Rachel Hardiman from the University of Minnesota. It's great to be with you. You know, we want to pick up the dialogue, Cindy, where you left off, because many of you have reported for years the crisis that's been ongoing in Black maternal health. We know that Black women in the United States are 3 times more likely to die from pregnancy-related complications than white women. And Cindy, to use your words, and I couldn't agree more, it's unconscionable and unacceptable. Now's the time, I believe, to confront health disparities and really reimagine a more equitable healthcare system. So a few weeks ago, Blue Cross and Blue Shield Association announced a new national health equity strategy to do just that. Our first focus is maternal health, and our goal is to reduce maternal health disparities by 50% in 5 years. In a moment, I'll share more about what we're doing to accomplish just that, working across the country with many, many different providers and entities. But first, I want to preview with you some data that we're sharing tomorrow for the first time, looking at this issue of maternal health disparities. We've analyzed about 2.2 million births covered by Blue Cross and Blue Shield companies in the commercial lines of business between 2018 and 2020. We looked at what we call, or we don't call, but the CDC calls severe maternal morbidity, or SMM. So as I just said, it's a measure that CDC uses. And really, it's about citing unexpected outcomes from childhood or pregnancy, like kidney failure, respiratory disease, eclampsia, which of course can sometimes lead to even death. And what we found was pretty startling. We found that SMM rates are more than 63% higher for Black women than for white women. We found that 32% higher SMM for Hispanic women than white women. We also surveyed Black women and learned a lot about their expectations and barriers too. In particular, we also found that Black women aged 24 and younger still have higher rates of SMM than white women over 35, who are traditionally considered higher risk. With respect to the survey that I mentioned, we found that Black and Hispanic women face barriers to getting the care they want, like prenatal visits, often because of things like transportation or inconvenient scheduling. It's clear we're failing Black women and women of color, and we need to do more. We know, of course, health disparities are complex. It's not a one-dimensional problem, so there's certainly not a one-dimensional solution. We have more to do, and the Blues are really committed to this effort. We're working with partners across the healthcare industry and communities across the country because it will take all of us to change the trajectory of health disparities. We're taking steps to create a more equitable system of healthcare through local programs and initiatives. So, for example, many Blue Cross and Blue Shield companies are seeking better outcomes for Black mothers when they offer doula services or provide programs to help at-risk women manage their chronic conditions. We're working with providers to ensure strong patient communications, culturally appropriate care, and effective outcomes. And one of our Blue Cross plans in Michigan, they've made implicit bias training available to about 20,000 providers in that one state alone. We're collecting data to measure disparities, improve outcomes, and address unconscious bias, because we know data is crucial to at least know the starting point and the progress we're making. As the saying goes, we cannot manage what we cannot measure. We've convened an advisory panel for top experts in the field and advocates for health equity, including Dr. Hardiman, to share perspectives and guide our efforts. We're advocating for public policies at both the state and federal level to improve access to healthcare coverage, because healthcare can't be equitable until people have the coverage they need. More specifically, we're supportive of the Momnipus Act, co-sponsored by one of our guests tonight, Representative Underwood, because it'll help address social determinants of health. It'll certainly improve access to health coverage, and it will also ensure our efforts are grounded in data and science. No single program or organization can solve the problems of systemic racism and unconscious bias that have caused so much hurt for so long. But I truly believe working together with communities, providers, partners across the country, we can meaningfully address racial disparities in healthcare. we can help pregnant women get the care that she needs and the care she deserves. We want to focus on health caring and not just health care. So thank you, and I look forward to the discussion and your questions.
Wonderful. Thank you so much, Ms. Keck. We'll start with our first question, which will be for Ms. Keck and Dr. Hardiman. Why begin the National Health Equity Strategy with a focus on maternal health, and why now?
Well, I think I will start in, Cindy. Thanks for the question. I think in some respects, you started our conversation this evening right now, right? We need to start with maternal health because of the scale of the crisis. It's really inexcusable that pregnant women in the United States are twice as more likely to die from complications than women in other countries that are also high income in the developed world. I mean, these are staggering numbers that you can read about. And we know that Black and Hispanic women are disproportionately impacted, as mentioned earlier, just because of the findings, rather, in our latest report. So the gap in maternal health is significant and really, in some respects, extreme. So we need to start there. We have made some great strides. So I feel confident that we are committed to this action collectively across the health ecosystem, but there's so much more to do.
Dr. Hardiman?
Thanks for that question, and thanks for convening this incredible event this evening. I'm happy to be here. And I think Kim described it perfectly, right? We're the only industrialized nation that has a rising maternal mortality rate right now, and that is unethical, it's unconscionable, and it needs to not be our reality. But I think in addition to that, as I think about, so from the public health lens, I'm a public health professor, I sit in a school of public health, and one of the things that we teach our students is that infant mortality in particular is a critical marker of public health, right? So when we are looking at the health and well-being of a community, of a neighborhood, of a state, we often use infant mortality as this important marker to tell us what's happening and if a place is thriving. And that's because, infants are some of our most vulnerable citizens. And I think the same can be said when we think about mothers, right? It goes hand in hand. And so, in my mind, maternal mortality, just like infant mortality, is an incredibly important marker of public health and well-being. It's a social issue just as much as it is a health issue. And therefore, we need to be starting with the question of how do we keep our moms safe? How do we keep our moms healthy? We saw over the past year, certainly, that mothers are the backbone of our families, of our communities, of our society. They hold us up. And so I think for all of those reasons, we need to be starting here. And certainly, the pandemic in the past year, as well as the sort of racial justice and racial awareness and awakening we've had over this past year have led folks to an understanding of sort of who's most vulnerable or who's disproportionately impacted in our community and has poor health outcomes. And I think there's no, starting with moms as we've, and taking what we've learned over the past year is incredibly important.
Thank you so much, Dr. Hardiman. I'd like to now go to Congresswoman Underwood, and then Dr. Hardiman again, and then CEO Keck. What are the contributing factors, the key factors, to U.S. maternal health disparities, and why are Black mothers continuing to shoulder the brunt of this burden?
Well, we know that there's nothing wrong with the moms. And I think it's really important to affirm that and be unequivocal about it. And so that means we need to look at the health systems in which these birthing people are entering for care. We need to look at the communities that they live and work and recognize that there is a foundation of racism throughout our society, including our health system, which means that one group of people continues to be more likely to die when seeking care. I think it's really important to recognize that this is a problem that we know how to solve. There are a variety of solutions that are on the table. We just need to have the courage to implement them, and we need to prioritize this problem and these solutions. And that's why I'm so pleased to be able to, acknowledge this report coming from the Blue Cross Blue Shield Association. How rare is it to see such a significant player in this space really take a leadership role in examining their own data, right? And make these types of commitments, because it takes all of us to save lives. When you ask about specific contributing factors, yes, we know that infection is a contributing factor. We know that mental health and suicide and overdose can be leading causes of maternal death. We know that preeclampsia can be a leading cause, right? It's multifactorial in many ways, and I'm sure Dr. Hardiman can give us the exact details, but from our point of view and the Black Maternal Health Caucus in the Congress, a bipartisan group of lawmakers committed to addressing our nation's maternal mortality crisis, we are committed to comprehensive solutions to address every dimension. So we're not only going to just tackle one thing, we want to tackle the societal issue and make sure that we are not continuing to live with this disparity, right, in maternal mortality and severe morbidity, like Kim mentioned.
Dr. Hardiman?
Yeah, I think Representative Underwood just explained it beautifully. I think what I would add to that is the historical context, right? Because I think we can't talk about maternal mortality and morbidity and the inequities by race without placing it in a historical understanding of this is not something that sort of has cropped up, in the past few years. It may feel that way because I think, frankly, the media has done an incredible job over the past 4 to 5 years of elevating this issue, and I applaud you all for that. But we have to actually go back over 400 years, right, to really think about what's happening here. And so, I think it's important to understand that, the link, the inequities we see in maternal health are directly tied to slavery, to the year 1619, and frankly, every year in between. And, until we're able to really dig into that history, right, and to understand the role that, for instance, the quote unquote father of modern gynecology, James Marion Sims, played in and conducting research on Black enslaved women, and all of the other sort of atrocities and things we haven't really sort of sat with as healthcare providers, as researchers, as folks, doing the work in this space, we're not going to be able to really, really sort of dig into the solutions. I think Representative Underwood also talked about the social context and the fact that, it's not just about what's happening in the healthcare system. It's also about what's happening in the lives of the people and the birthing people and their families before they even walk through the doors of the hospital or the healthcare system. And that, again, is also tied to our history, right? So when we think about where people live, the social determinants of health, so where people live, work, and play, and why that matters for their health, we have to be able to step back and think about the fact that structural racism in particular has dictated where certain folks, where Black folks in particular, have been able to buy a home, have been able to build a life. And therefore, where they live dictates, perhaps their access to healthcare. It certainly is going to bring up a variety of other stressors and things in someone's life. And we know from incredible research, even from the early 90s, that the weathering, the cumulative disadvantage, and that chronic stress over the life course is wearing and tearing at Black bodies in a way that it's not for other folks who are privileged in our society. And so, we have people who are then walking into the doors of our hospitals already at a disadvantage, right? Already not as healthy as they could be because of the structures and systems that they've had to navigate. And then they walk through the doors of a healthcare system that hasn't reconciled and hasn't thought about or talked about or the historical context of race and racism in healthcare delivery, and then therefore is not well equipped to serve the patient population as they come through the doors. So we have to be working at these issues from a lot of different complex and multifactorial angles, as Representative Underwood just described as well.
Thank you so much, CEO Keck.
You can call me Kim, but it's hard to add to anything that both Representative Underwood and Dr. Hardiman said. I mean, those are incredible, eloquent, comprehensive answers. I guess just a little bit I'd say, and this is trivial, but I'll say it anyway. I think, as I think about Blue Cross and Blue Shield companies across the country, as you said in the beginning, Cindy, right, we insure 1 in 3 Americans. So we are traditionally considered, and we are an insurance company, a payer, if you will. But Blue Cross, and I've worked at other places, and Blue Cross Blue Shield companies in particular are inculcated into the community. And to me, so many of the issues that both Representative Underwood and Dr. Hardiman talked about are rooted in the community. And so as payers, as health insurers, if you will, we have got to do just that, inculcate ourselves into the community, particularly community workers. And we're doing so much on the social determinants of healthcare, but we have to really pinpoint our efforts. And I can't add any more to the key factors and the reasons. Really well said, but I'm optimistic that we are leaning in new ways. And thanks to all the people here that are elevating and leading these issues. And it feels, look, it's just time. It feels like we're, committed in different ways in 2021 than perhaps we've even seen in the last several years.
And can I circle back to you and have you speak to the importance of the quality of a woman's maternal experience? For example, her confidence in the care she received, or her comfort in speaking openly with her provider in closing the disparities gap.
Yeah, it's so important. And Dr. Hardiman touched a little bit upon this when she was talking about public health and the indicators of public health, but and particularly the infant's health, in particular. But I would say the quality of care that a woman receives is so important, right? Because this is likely to experience whether or not women might even have complications and what happens after birth or pre and post birth. And so that's one of the reasons in the report that I mentioned earlier, we did survey moms and we asked things like how confident they felt that they get the care they need and therefore are able to manage potential risks or even complications. And, unfortunately, Black and Hispanic women said they actually didn't feel confident that they would get the care they need to manage risk for complications. So I do think it goes back to what we were talking about a moment ago, right? This is a really complicated issue. There has to be multidimensional approaches. So some of the things that we are doing that we need to do more of, but I would just mention is, identifying women who are at risk. We are providing coaching to those women today across different Blue plans to help them manage their chronic conditions. We're addressing underlying social needs that we know, just mentioned a minute ago, have significant impact on health. Or we're doing things like culturally competent screening for postpartum depression. We haven't really talked a lot about postpartum depression yet. And really getting back into the community, right? Inculcating back into the community, even with the likes of community health workers, to really help get at this quality issue, because prenatal care and post-delivery care are so critical to the overall success of our efforts on maternal health disparities.
Congresswoman?
This is so important. We have a bill. So the Momnipus is a comprehensive suite of legislation, 12 bills to solve every dimension of our Black maternal mortality crisis or Black maternal health crisis. And one of the bills is the Perinatal Workforce Act, which makes key investments to grow and diversify our perinatal workforce. So more OBs, more midwives, more nurse midwives, more lactation consultants, more physician's assistants, more doulas. We believe that every birthing person in this country should have a choice in their providers. It shouldn't be limited by geography. It shouldn't be limited by race or cultural background, language spoken. If someone's looking for someone with the same religious affiliation, right? We believe that there should be choices. And right now we just don't have the diverse workforce to meet that need. This is how we're able to help solve for this problem. One of the things that we haven't touched on in the conversation yet is I often say in conversations like this, the single most important thing that we can do to save moms' lives in this country is to deal with Medicaid. But what I think is because the Medicaid program pays for 2/3 of all births for African Americans in this country. And we in the Congress and the Biden administration, through the American Rescue Plan, extended postpartum Medicaid coverage from the 60-day statutory timeframe to 1 full year postpartum, which is the gold standard for coverage. However, we are here this evening with the CEO of an insurance company that just walked us through the data that documents what we know to be true, which is the disparity persists even when a Black birthing person has healthcare coverage, sees their provider, right? Does all their prenatal care. You can do everything right, and the disparity persists. And so I think that this really gets to an important point, and why it's so important to really tease out the data. There's something fundamentally wrong. And insurance coverage, right, or access to care is not the only solution. It's an important solution. It's an important piece of this pie, but there's still more that we can all do, which is why we're so excited about the Momnipus as a solution.
And Dr. Hardiman, can you talk about the Black woman's experience in this process, and why, with everything equal, everything being done right, access to care, that the outcomes are different?
Yeah, I would be happy to. And I think, that there's two things that are important to highlight first, and that's just underscoring what Representative Underwood just said, that even with access, we see inequities, right? And the other piece is that we didn't mention earlier is that the maternal mortality gap persists despite socioeconomic status, despite education levels, right? So even the most educated Black woman, we watched it play out, right, with Serena Williams, an incredibly wealthy person, right, and who has a lot of resources and also suffered from less than optimal quality of care during her birthing experience. So I think it's important to note that Black women are at risk despite the level of SES, the level of education they've achieved. And we know that even with access, right, these inequities, these disparities persist. Some of there's a wide body of research that, we could spend all night kind of going through that describes sort of what's happening in these clinical encounters where women are reporting, or birthing people are reporting not feeling heard, feeling disrespected, not having autonomy over their care. Some of my research has shown that Black birthing people who do speak up in the clinical setting or during childbirth hospitalization then report feeling penalized for having spoken up, report feeling discriminated against by their provider because they spoke up and decided to decline a certain procedure during the process. Some of my other work has shown that when Black infants, we looked at 1.8 million births in the state of Florida over 15 years, and we found that when Black infants are cared for by a white physician, they are more likely to die in the hospital. However, when they're cared for by a Black physician, that mortality penalty is cut in half. So we have all of these different sort of things happening within both outside of and within the healthcare system that are eroding opportunities for high quality, equitable healthcare. And, we have to be able to sort of dig into that and figure out the reasons behind it.
And so let's continue with that discussion about the solutions. What are some immediate actions that we can take to begin to solve the Black maternal health crisis for good and to really make a difference in people's lives? Dr. Hardiman, go ahead.
Yeah, okay. I think we just heard some wonderful solutions from Representative Underwood, support the Momnipus Act. I think every piece of the Momnipus Act is right on target of what we need. A lot of my work has focused around how do we create anti-racism training and implicit bias training for perinatal care providers, for all healthcare providers really, but perinatal care providers and their staff. I've been doing a lot of work in California where they actually legislated and passed legislation that is mandating that their perinatal care providers in the state go through implicit bias and anti-racism training. And I've been working with the California Healthcare Foundation to create that training for those providers. And I think every single state and every single OB unit, clinic, midwifery organization should be doing the exact same thing. We need to really invest in culturally centered care. And in order to do that, it means that we have to desegregate the healthcare workforce. We know right now that Black people make up 13% of the population in the United States, but only make up 4% of the physician workforce, and even fewer of them are OBs. The midwifery statistics look very similar. We need, and as well as doulas, we've done a study here in Minnesota to look at how many doulas of color are available in our communities, and it's not nearly enough. And so we need to be thinking about policy solutions that allow for a pipeline. And we can't wait, right? The pipeline of starting young is important and should be invested in as well, but we need immediate solutions to these issues as well. And so I think we need to be thinking about how, as Representative Underwood said, how to make sure that all birthing people and Black birthing people in particular have choices.
And Representative Underwood, could you talk more about the specific bills and actions that are underway right now in Congress?
Yes, ma'am. So the Black Maternal Health Momnipus Act of 2021, HR 959, has currently been introduced. We are looking for co-sponsors. So each of you watching has one representative and 2 senators, and you can literally call them and say, please co-sponsor the Momnibus. We need you to do that. Within this bill, this is a data-driven, evidence-based bill. So we have the social determinants for moms bill, which is dealing with housing and transportation and nutrition assistance, right? Expanding WIC, evidence-based solutions that we know will save moms' lives. In my state of Illinois, the #1 cause of maternal death is related to mental health and behavioral health, suicide, addiction issues, overdose, right? What happens for a mom in a community when her issues go beyond postpartum depression? We have a culture that we know how to spot postpartum depression in our girlfriends. We know how to check in. But what happens if it's anxiety? What happens if it's an addiction? What happens if it's something more needing an additional intensity of care? We know that there's not providers in every community prepared to care for that birthing person, and certainly not in a culturally relevant way. COVID-19, my goodness. COVID and pregnancy have just been a tough combination from the very beginning of the pandemic, when we were told to stay out of our healthcare system, and those birthing people going into delivery knew that they were entering into a health system where they might not be heard, they might not be listened to, and all of a sudden their support person was taken away. Their spouse, their partner, their doula, not allowed into that delivery room with them. And it's no surprise then we see the outcomes, which show that Black and Hispanic birthing people are more likely to get severe COVID when diagnosed. And if they have COVID, they're more likely to have a negative maternal health outcome. That data came out from, I think that was the MWR, the CDC's scientific journal last summer. So we have 2 bills in the Momnibus related to COVID, one of which is dealing with the maternal vaccination issue, right? Pregnant people, lactating people, postpartum people were not invited into the clinical trials. And so even now today, we do not have a clear recommendation for whether or not those folks should be vaccinated. It's unacceptable. When we have special, important subpopulations, vulnerable groups, we need to make sure that we are providing for them in a public health emergency, right? So that's in the Momnibus. The last thing I want to call out is related to climate change. Last summer, there was an article in JAMA talking about the impact of extreme heat and air pollution on maternal and infant health outcomes. And I saw that and I was like, whoa, we missed it in our first iteration of the Momnibus, which we had introduced last spring with then Senator Kamala Harris. And so we wrote a new bill, literally in response to this data coming out. And so we need your help to get this legislation passed out of the House, passed through the Senate, and signed into law. The sense of urgency that I feel about this work is because we know that every day somebody is dying of a preventable cause, preventable. And we have the solution right here. We just need to get across the finish line. So would love your help.
And Ms. Keck, can you talk a little bit about some of the immediate solutions that are built into the blues?
Yeah, absolutely. So first, I'd just start off where Representative Underwood was finishing. Look, we are a strong supporter of the Black Maternal Health Caucus and the Momnibus package more broadly across the blue system. So kudos for your leadership and all of the components of that incredible package. because we, as we've said several times just on this one call this evening, right, no one of us can do this alone. These are systemic issues that have been with us, as Dr. Hardiman said, for 400 years, right? So we need public health experts for sure. We need policymakers, we need advocates in the community, we need providers. We talked, of course, about midwifery and doulas, but one of the things we're also looking at in the Blue Cross Blue Shield plans, in addition to incenting providers on unconscious bias training, and we have 1.7 million in our network, is also, what we might not pay for, right? So if you think about, I don't remember what never events were, maybe 15, 20 years ago, right? When, the Institute of Medicine said, one of the biggest issues in medicine is errors, and we should not actually pay for errors in medicine. So maybe we actually shouldn't pay for things when there's, hemorrhaging that shouldn't have hemorrhaging in childbirth, for example. So we're looking at bundles as one way to say, look, how can we not just use all of the positive reinforcement, but are there more? There are some things that we know work relatively well, and we have several examples across the country. None of these are the solution in and of themselves. Absolutely, positively not. But for example, we have some impressive work underway in Mississippi, I believe. We have some of what I was just talking about, some safety bundles, right? Evidence-based toolkits and training. It's more probably carrots than sticks, but really get at the whole notion of responding or even incenting treatment of SMS indicators. One of our plans in Philadelphia, Independence Blue Cross, is building predictive analytics. It's more than building. They actually even have the predictive analytics to look to say, how do we identify high-risk pregnancies and proactively connect pregnant women to the community resources before they need them, before they even want to seek them out, and make those connections. We have another plan in actually several, now that I think about it, that are promoting programs preventing SMM indicators through the trainings led by the March of Dimes. We have some additional community-based programs on education, nutrition counseling, food share, culturally sensitive care. Right, as you've heard many times already this evening, there's just no one solution. And so as we think about it, what we're trying to do most prominently is leverage what works. It's finding the ways that work today and new ways of work, looking at how to make these kinds of programs that are just articulated available, more people, more communities, and again, move beyond healthcare to health caring.
Thank you so much. And I wanted to ask all of you, but particularly Congresswoman, about some of the acceleration that we've seen during COVID-19 and some positive programming. For instance, when everything went virtual, CMS decided, the Centers for Medicare and Medicaid Services decided that they could pay for virtual visits equally to in-person visits for a lot of different kinds of physician-patient interactions. You could suddenly establish the physician-patient relationship online. And people who were licensed only in one state suddenly became a provider in many states. And so how does that influence the kind of care that birthing people might have at home and along the way in this environment? And will we see those types of programs retained?
So we do have a provision in the Momnipus, the Tech to Save Moms Act, which does address digital tools like telehealth. However, and I want to be very clear about this, telehealth is a tool. It is not the solution. And more than that, it is not even an evidence-based solution, particularly for this population that has been proven that it will save lives. And so in Congress, some of my colleagues are not interested in investing in healthcare. They're not interested in investing in providers. They would rather pay to give everybody a cell phone and say, talk to your provider on your phone, right? And that is what we don't want. So I always say that it is part of a comprehensive solution, but we need to be very, very, very clear that this would not have prevented the COVID-related escalations, right? It doesn't solve the disparity. And, you know, certainly when we talk about workforce issues, the answer is not to overload the very few providers of color that we have by connecting them with every Black birthing person in this country. We need more providers.
Gotcha. Dr. Hardiman?
Yeah, I would just add to that there's also an access issue, right? We know that folks in rural areas and certain geographic communities don't actually have access to broadband in the same ways. And so we're creating another layer of inequities and disparity, you know, by relying solely on telehealth. But I do think it's important within the COVID context to remind ourselves, you know, you, Cindy, just rattled off a couple of things that changed really quickly, right, in response to the changing landscape of COVID. And to me, that's what's important, is the fact that we can innovate and we can change if we want to, and we can do it really quickly. All of these seemingly sort of really big policies and sort of bureaucracies that we have always faced, like all of a sudden we made some decisions to change them in the face of COVID. And so I think we need to be treating the maternal mortality crisis and racism in the same way, right? As a pandemic, as a crisis that we need to move with a different level of urgency than we have in the past.
Gotcha. Ms. Keck.
Yeah, I would add a couple of things. I'm so glad my colleagues actually started with not evidence-based, because when a payer says these things, you know, people squirm a little in their seats, and I understand why. And, you know, when I talk to physicians, I didn't go to medical school. I don't have initials in front of my name like Dr. Hardiman does. I don't know if that's a PhD or an MD, and I should know that, I forget. But I didn't go to medical school. So I can't say this firsthand, but what I do hear from many physicians is, look, don't underestimate the value of seeing someone in person, of being able to diagnose by seeing a patient and understanding their complexities, right? A lot of people wanted the convenience of telehealth. There's absolutely positively no doubt about it, right? But you can't do everything over telehealth. We know, and this is not necessarily a Black maternal health issue per se, but a related issue, right? Telehealth, we had to do it. I absolutely agree with you, Dr. Hardiman. We were incredibly innovative in a time we had to be incredibly innovative. And there are two things I'd say about that, right? We largely in this country still pay for doctors and hospitals on a fee-for-service basis, right? You actually go to get a service, you get paid a fee. And when the pandemic came and we were all asked to say, hey, no, everybody stay home, don't actually seek services, there were no fees. So for lots of reasons, because it wasn't safe to leave, we had to innovate. But also, candidly, providers were, you know, in some significant financial distress because they weren't getting paid any money. And so telehealth was a great innovation. But, and not a but, and one of the things we know in 2020 is childhood immunizations across our population were down 25%. CDC reports similar numbers. And actually CDC does report it by race. And I don't think the numbers are any better. I can't recall them off the top of my head. It's not going to happen. You cannot use telehealth for an immunization. And I would also say, I actually love your analogy, Dr. Hardiman, because I often say, like, imagine if we took all this energy that we used collectively as a country, like 1 year less than COVID first even came on shore, at least that we know the first case of COVID in the United States. Within less than 1 year, we had a vaccination created, administered, distributed in arms. Like, imagine if we channel that and say, look, let's do that. Let's take the Momnipus and let's actually implement all of that. Let's start now. Let's see what we can do in the next 12 months, and then the next 12, and the next 12, and the next 12. We gave ourselves 5 years on this 50% reduction. Dr. Hardiman, you were part of the panel that said you might want to move faster. And we agree, we do want to move faster. But look, we want some momentum, we want some partnership, we want some energy behind this too. And we can do it. There's no doubt about it, we can. But we have to start, and we have to start in meaningful ways. So I'd pause there.
So something that has been raised during our discussion, but we haven't delved into deeply, that I'd like to pursue a bit, is about maternal mental health and about how that affects the lives of the mother, the lives of, you know, at the end of the day, we want a well mother so we can have well children. And we also, I think Congresswoman raised the issue of, we have people who aren't here anymore. And so we've lost the mothering, we've lost a parent, we've lost maybe an income earner, we've lost devastated families are the result of a lot of this. And I just wanted you to talk a little bit about the mental health issue, particularly the postpartum issue. A lot of people think that's just a few days after people give birth. That's a whole year, technically, after people give birth, as the Congresswoman mentioned. So let's talk a little bit about mental health.
Well, what I would just say is part of this issue is a data collection issue. So we know, for example, in my state, it's the leading cause of death, but the way that many states measure maternal death, if it doesn't have an explicit linkage in that death report to the pregnancy, it doesn't get counted. And so that's part of the challenge with this issue, is that our healthcare has been so fragmented. If someone dies either by suicide or overdose, that's usually where it really plays in. It might not even be collected as part of our maternal mortality surveillance. And so that's part of why in the Momnibus we have, I forget what it's called, but it's about data collection to clean up that issue. But I do think that this idea of needing care in every community, normalizing that care, it's not just therapy, right? Like, from like a therapist or a social worker or psychologist or psychiatrist, there also is a considerable, I think, behavioral health and treatment component. And that is where, again, we can circle back to the access. That's where it's so powerful that we can have Medicaid coverage for the full year postpartum. That's when it's so powerful that we can have great partners like companies like the Blue Cross Blue Shield Association, who are committed to following the data and the evidence and saying, we need to make sure that these postpartum people understand how important it is to have continuity of care. And the last thing I'll say on the mental health piece, well, maybe I have two things. The first is a lot of my colleagues like to talk about Narcan Naloxone. And one of the things that we've been hearing from folks is that there is a little bit of an issue with access to naloxone, depending on that insurance status, right? And so we want to make sure that as people are getting their postpartum coverage, they have access to the medication-assisted treatment and these kind of emergency rescue tools. And then the second thing is, when we talk about suicide, we have to actually talk about it. You have to actually raise it and, do that kind of probing clinically. You have to ask about access to firearms. Like, you have to do all of that. And I think that that has not necessarily been normalized. And I think we have work to do culturally when we talk about severe morbidity and its intersection with addiction and psychiatric disorders. We've got to do better, because our moms are dying and we're not serving them well.
Dr. Hardiman?
Thank you. I'd love to add to that, and I'm glad, Representative Underwood, that you brought up the surveillance piece, the data piece, because I serve as the co-chair of the Minnesota Maternal Mortality Review Committee. And I think, what we're seeing is exactly what you described, right? There's this disconnect between the way that the information we have to be able to review a maternal death and to really have a clear sort of and robust understanding of what happened, what transpired. And our goal as a review committee is not just to honor that loss, that life loss, but also to make policy recommendations, and to think about how could this have been prevented? Because as you said, 60% or more of these deaths are preventable. And I think we need to do a better job at being able to track maternal deaths and the reasons behind them, whether it's mental health or postpartum, depression related. We do see a lot of overdose and suicide right now. Domestic violence is also an important part of the mental health and the postpartum mental health piece. I spent this afternoon in conversation with a Black midwife here in Minnesota who has a freestanding community birth center called Roots Community Birth Center. And we were specifically talking about her postpartum model of care and the fact that anybody who births at her birth center or receives care, they don't actually even have to have birth at the birth center, but if they've received prenatal care there even, but end up birthing elsewhere, they get a home visit at 24 hours postpartum, another home visit at 3 days postpartum, another one at a week postpartum, and then sprinkled in there are 3 more visits where the family comes into the birth center. And now they're thinking, okay, what does a year postpartum look like? And I think we haven't even scratched the surface of thinking about how do we, now that if we're going to offer access, right, as we should to birthing people for a year postpartum, what do they need and what does that look like? And I think we have some really important opportunities, certainly from the research side of things, to think about, what's the evidence around sort of what people need and how do we make sure it's culturally centered and evidence-based.
And CEO?
Yeah, I would add a couple of things. I couldn't agree more with my colleagues' comments. I think we started talking about postpartum depression. And, it's amazing because even on this issue of postpartum depression and data, we don't even really have great statistics because, at least Black mothers, because the rates of postpartum depression are just really never diagnosed, right? I think generally we know 1 in 9 experience postpartum depression of all mothers. But, I think the numbers could be far worse, I'm afraid, for Black mothers. And to this notion, Dr. Hardiman, you just talked about like this continuity and not just even a year. We have seen one significant, actually a program that's worked pretty significantly in Baltimore, Be More for Babies. It was a collaboration with lots of different entities in the city of Baltimore to address maternal mortality, infant mortality, maternal disparities. And that particular program, Care First, is Blue Cross Blue Shield plan in that state, and they were part of the process as well and part of the program as well. But community workers, community health workers went into a mom's house that had given birth up to the 2nd year of the baby's life, right? So it wasn't this sort of episodic 3, 6, 9 days, months, it was up to 2 years, and pretty stark improved outcomes in terms of overall health of the mother and mortality of the child. We also, to this notion of just postpartum in particular, we have one plan in Rhode Island, and sort of this is a combination of a lot of the things that we've talked about, that is paying pediatricians to add staff, social workers at a minimum, case managers, care coordinators, who can address postpartum depression of the mom if they're able to bring their baby in for even their well visits, their visits after the baby is born. And doing the screening live can help moms avoid having the potential hassle, or more than hassle, in some respects, sometimes these moms can't actually get back for a second trip because life gets in the way. So doing that while the baby is in the office for that screening is, I think, one of the things we've seen work relatively well. We also have some additional programs in the state of New Jersey, working with the state Medicaid agency there, the largest health system there, to really dig into root causes behind postpartum depression, in particular in health disparities and postpartum depression, to find the best ways to intervene. Some success there, but more to learn from that program.
Thank you so much. And the last question as we wrap up, I always like to ask panelists during discussions like this, what journalists can do, how we can change the way we approach, what questions can we ask, who we're not talking to, how can we provide better communication to communities, to readers, viewers, listeners, that help people in community move this process along so that we can have better outcomes for moms and babies.
I can start simplistically by saying, doing things like this, listen, be fact-based, right? There are so many things to write about this crisis that are fact-based. This isn't an opinion. This isn't anecdote. This is heavily researched. I mean, you even heard many, many different examples today, and we have experts on this Zoom call tonight who actually have done the research and have sponsored the legislation to actually make a difference. So continue to write, continue to ask the right questions, and publish the facts. These are pretty stark reality. And the more we can make it, not just the headline for this week, not the headline for this month, this is a crisis. And I'm not trying to inflate it. it is a crisis. And so let's actually give it the energy it deserves to start focusing on some of the solutions. There isn't one solution. So this should be an ongoing story, because it will take us time, but we have that time, we have that commitment, and write about the energy that we can collectively devote to address this crisis.
Dr. Hardiman?
Yeah, thank you. I agree with everything that Kim just said. I would add, I would underscore first the focus on solutions. I think that journalists, and Black journalists in particular, have done an incredible job, as I said earlier, over the past few years of really telling the story and getting, maternal mortality and an understanding of racial disparities in maternal mortality out into the general public. And so certainly continue that work. But I also think it's important to turn to solutions and to really begin to highlight the pockets and the areas of places and things that are going really well, and that we want to lift up, and making sure that, and I think the other part of that is shifting that narrative, right? So I have so many friends who are, have been pregnant in the past couple of years, Black women who say to me, based on all these headlines, like, am I going to die? Like, what, and they're fearful. And that's no way to spend 9 months, and so I think we need to be, while continuing to raise awareness, also we need to lift up what's going well. And I think the other part of that is that, we need to center Black birthing people and Black scholars and Black physicians and Black folks who are doing this work. So the Black Mamas Matter Alliance has done an incredible job over the past few years of elevating this issue and centering Black birthing people and their families and in the work in ways that I think has been really powerful and really important. And it's shifted that narrative from one where, we first heard that, well, Black women are dying more frequently because they come into pregnancy older, fatter, sicker, less healthy. They don't take care of themselves. They, don't go to their prenatal care appointments. And we've slowly seen the understanding shift, I think, in the at a population level, to understand that, no, it's the structural inequities, it's structural racism, and racism in multiple forms that has contributed to the inequities we're seeing, but we still have a lot of work to do. And I think the other part of that narrative that I hope that media continues to put forth is just that these are people who are loved, who have families, who are important members of our society and our communities. I review each and every death of a mother that happens in the state of Minnesota, and every single one breaks my heart. And it's painful on so many levels. And I think by elevating, making sure that those losses aren't in vain is incredibly important.
I would just add, in 2017, one of my girlfriends from graduate school died, Shalon Irving, and her story was told by ProPublica and NPR. And it was incredible that we could see her story told in such a comprehensive way. Since that time, I've witnessed it moving from niche publications, I will say, to like not only news media, but like cultural, like People magazine reporting on maternal deaths, and not celebrity, but like in their like human interest, right? Like, oh, this is an awful, sad story. We are watching culture change. We need our policies to change as well. And so I think, as a society, need to continue to put forward and socialize these evidence-based solutions. Unfortunately, in the Congress, everything is done in a partisan lens. This is not a partisan issue. These are not even, at least they shouldn't be viewed as partisan solutions. And so as these stories are told and this reporting is done, particularly on the policy part, I would just ask the journalists to keep in mind that how it is framed often dictates the outcome. And if we continue to advance a narrative that it's just Black people asking for this problem to be solved, then that allows for a partisan framework to creep in that says that other people don't have to care. When in reality, when you look at the map and who represents folks, it's not just people of color who have the quote responsibility to solve this problem. And I think that that is the story that has not been told yet in the press. And so if someone wants to write that piece, I'm happy to go on the record, but y'all don't want to hear from me anymore. I've said my piece. Thank you so much for your interest and for pulling together this panel tonight. It's an honor to participate.
Thank you so much, Congresswoman, and thank you, Dr. Hardiman. I'd like to wrap up by saying that this wonderful new report, The Health of America, will be released early tomorrow morning. Is that correct? Yes. So we'll look forward to that. I want to thank all of our panelists again for joining us, and thank the National Association of Black Journalists for continuing to highlight the important and critical issues. And I'm Cindy George, and thank you so much for joining us, having a great rest